So coming to how we deal with the certain particular side effects. So coming to the side of cardiovascular effects, we all know that estrogen is cardioprotective. The oxidation of LDL and cell formation causes the endothelial injury and the smooth muscle proliferation, leading to the atherosclerotic. That means the plaques and all will be formed. So this is the reason why men are more prone for heart attacks compared to women. That's because women have estrogen. They and the effect of the estrogen, till the effect is there, they were at a cardioprotective stage. Once they enter into menopause, it's the same risk compared to men. That is why if the woman has a family history or she's already having a high risk factor for this cardioprotective, then it makes sense for us to start it early, so that she doesn't land up with all those events. Carotid intimal medial thickness is also a good predictor, and it also is a non-invasive marker of subclinical cardiovascular disease. We have to make sure that, if a woman is being started on HRT for the cardiovascular protection, it should be given only during the early phase. If you're planning to give it after 60, it is not recommended. Why is it not recommended? Is in early changes, there are no changes at all. There is, if you give HRT, there will be increased vasodilation, in an increased decreased inflammatory activation. Whereas if you already give it in an established atherosclerosis, then there is decreased. Basically, the concept of you giving HRT in an already atherosclerotic patient will cause more harm, because it's already damaged. It's already, the smooth muscle is already proliferating, the foam cells have formed. So if you give HRT, then this will just increase this and it will cause more damage. So make sure, if you're starting the woman only for the cardiovascular thing, give it in her earlies. If you give it after 60 years, this might be what her blood vessels look like. So you will cause more damage and she will end up in a coronary artery disease, and you will be responsible for that. So always be careful before starting it for this. That is why, if you're planning to start a woman after 60 years, make sure that her cardiac profile is normal. This is what I told just now. Okay. So genitourinary syndrome of menopause, it's also called as GSM. This includes both all the vaginal dryness, the urinary symptoms, the decreased libido, all the symptoms. They have there's a new name called as genitourinary syndrome of menopause. So in estrogen, it helps in the maintenance of the vaginal epithelium and the urinary bladder. So once the estrogen decreases, your vaginal dryness and dyspareunia, dysuria, all these symptoms can be there. So in these, even minimal trauma, scratching and all also could cause bleeding over there. Okay, so and urinary symptoms, repeated and recurrent urinary tract incontinence and stress incontinence are very important for these important symptoms which these women complain of. Also, women do complain of female sexual dysfunction. So this could be because of the central acting effect of the estrogen. So in these women, vaginal creams, the local use of estrogen is the best, because it bypasses all the systemic side effects, and you will just be giving the cream or the tablet or the vaginal ring, which has to be applied locally. And it, even if you give it for only if she's having only the complaint of dyspareunia or dry vagina, if you give it, her urinary health also would be better. So you can start it with a very low dose cream, 0.625 mg. You can titrate it up to 2 mg if required. So these are the available creams and the tablets which can be used. Next are the vasomotor symptoms. Vasomotor symptoms are hot flushes. These are due to perspiration and cutaneous vasodilation. Both are because of the central acting effects of the estrogen. So these coincide with the GnRH pulse secretion, because there is no negative feedback. The LH levels keep on increasing, and the GnRH also has a pulsatility action. So generally, when those hormones are released, that is when your hot flushes happen. So generally, they last for about a few minutes, but sometimes it becomes very unbearable for the patients, and the sleep is disturbed, mood swings, and all. This can cause an array of different symptoms. So we have to understand that the thermoregulatory center is the main culprit in the vasomotor symptoms. So for them, these are the options which can be offered. The first thing would be the lifestyle changes, to do some yoga exercises, to stop smoking if she's a smoker. And then you can start, non-prescription medications like isoflavone supplements, and then, decide on, hormone therapy and non-hormonal therapy. So if she has depression along with the vasomotor symptoms, SSRIs and SNRIs are good choices. And if she's only having vasomotor symptoms along with other things which she has, estrogen. So if you are giving only SSRIs compared to, like, so there have been many trials which have been done, like the HOPE trial and all. So in these, if we have seen that, compared to the placebo, women who have been given non-hormonal medication, for them, the decrease in the symptoms was around 40%. 40 to 50% is a good amount of decrease. Whereas in compared to the hormone therapy, which is estrogens, and estrogen progesterone therapy, the 50 to 70 to 80 50 to 80% of the symptoms have been decreased. Even though the estrogen therapy is far more superior compared to this, if a woman is contraindicated to that, this comes as a very good second option. So these are the hormonal preparations which you can give, the oral transdermal patch or the gels which you can give. Next, coming to the most important topic, osteoporosis. So following menopause, the bone density decreases drastically. So, and it's almost around 5% per year during menopause. So osteoporosis could be type 1 or type 2. We have to make sure it's because of age, it's type 1 osteoporosis and not type 2. And every woman after menopause has to undergo, DEXA scan, that is dual energy X-ray absorptiometry. This is very important to see the bone density. And depending on the Z score and T scores, we can decide her whether she requires any treatment for that. The initial first line treatment for any osteoporosis is calcium and vitamin D. Once after giving that, also, if we do not see that, her bone density is not increasing, then we can consider HRT, which includes Premarin, or we can give bisphosphonates, which includes zoledronate and alendronate. Or we can also give the denosumab, is also a monoclonal antibody which has been given. We can give her 6 months once injections. If it is type 2 osteoporosis, then the recombinant human parathyroid hormone, that is teriparatide, can be given, which have, or calcitonin sprays can be given. Raloxifene also has a little benefit, but we have to make sure that, that she doesn't have, make sure that, when we're doing the DEXA scan, we do all the parameters, the spine DEXA scan and the hip and the femur. So because a woman is more prone for fractures after her menopause, we have to also explain her, the basic things that, the risk of fall injuries, how to prevent her from that. Her vision should be checked, and all the other basic things also have to be made sure. So we have to put her on safety precautions at home. These are the basic things which has to be done before starting her on hormone replacement therapy. Okay, so use of HRT for women more than 60 years. As I told you, healthy women can begin the treatment before the age of 60 and can use it, indefinitely. But if the symptoms appear many years after menopause onset, we have to rule out the other differential diagnosis. And then try with vaginal treatments or the transdermal patches first, because that are more safety, they're have a better safety profile compared to the oral things. And the duration, textbook wise, it is a short period of 5 years or so, and the dose should be reduced. But if the woman is doing fine, you can go ahead. Now, required duration is the norm. That is, if the woman is feeling, fine, then you can continue the HRT. There's no steady and fast rule that you have to stop at 5 years, but you have to counsel regarding the risks and benefits of continuing the HRT. The risks of HRT are there is a high a little, if she's you have, this is why you have to tell her to go with the proper follow-up, because she is at a high risk of developing endometrial cancer, breast cancer, venous thromboembolic disease, lipid, and high dyslipidemia, and a risk of coronary artery disease. So these risks have to be explained to her, and these have to be checked every time she comes annually to make sure that she's not having any of these. So this is a high risk. This is a special scenario in which HRT for women at high risk, that is the breast CA, who, if they do not already have been treated. So if estrogen, HRT with estrogen alone is associated with no change or very little change risk of breast cancer, whereas HRT with both estrogen and progesterone can be associated with increase. So estrogen alone is safe. Progesterone is the one which increases the risk. So here it is dose and duration dependent. There is no effect of the estrogen dosage. Estrogen does not cause anything to the breast. So a combined HRT is better compared to the sequential HRT, and vaginal estrogen is best. There is no risk at all. And compared to medroxyprogesterone acetate, micronized progesterone and dydrogesterone have a better safety profile of having. There are selective estrogen progesterone modulators such as tamoxifen, which also are used for the treatment of breast CA. In women who have endometriosis when they were in the reproductive age group, endometriosis, as we know, is dependent on hormones. So once they develop menopause, and then they are a little special high risk patients. So the decision to prescribe HRT or not has to be decided after proper counseling and the patient's involvement in the decision. There are not many studies as of now to clearly say whether it is safe or not, but we can consider the other non-hormonal aspects like tibolone and all, and we can also consider phytoestrogens and selective estrogen receptor modulators in these kind of women. We still need more studies to tell a particular guideline regarding this. But if a woman is insisting on having HRT, if she's gives you assurance that she's going to follow properly, you can try normal HRT with her. So the last slide, this was a very long lecture, but conclusions regarding the HRT entire topic is HRT continues to have an important clinical role in the management of menopausal symptoms. The current evidence does not support the use of HRT for the prevention of CVD or other chronic diseases. CVD is cardiovascular disease. But due to increased risk of venous thrombus embolism and stroke or breast CA in all the age groups, the best candidate for systemic HRT are recently menopausal and symptomatic women in general good health. This means low absolute risks, and the woman will have a better quality of life. The risk stratification and personalized approach to decision making is very recommended. Do not, if you are planning to go for HRT for any woman, or if you are a woman who is thinking of getting it yourself, remember everything is not there are no particular guidelines regarding this. It is always an individualized decision. So a woman will have a certain set of parameters, and according to her, the best choice of treatment would be considered. So the additional studies of different hormone therapy formulations, doses, route of delivery, and the non-hormonal options are needed. So we are still a long way in the studies and all. So we will, in the future, maybe there will be particular guidelines regarding all these stuff. But as of now, it is a better, we do lowest dose possible for lowest time of period if the woman is symptomatic. If she is feeling better with those, you can continue it if she's on good follow-up, and it's better to start as early as possible the HRT. Thank you.